Thank you, Madam President of the jury, for giving me the floor. Good morning, Madam President, honorable member of the panel, ladies and gentlemen. I'm Pierre Ongolo-Zogo. I feel privileged to stand in front of you this morning to defend my doctoral dissertation entitled Evaluating Initiative to Support Evidence-Informed Health System Policy Making in Cameroon and Uganda, case study of EVIPNet-Cameroon and REACH.
Dr. Pierre, confirm if they can hear you.
Are you getting me?
Do they see a slide?
Are you seeing my slide?
Maybe you ask them. Professor Göran.
Are you able to see a slide?
Yes, we can hear. We can see him. We can, see the slides, and we can hear it.
Okay, thank you for the feedback. The conduct of this doctoral research project was supervised by Professor Nelson Sewankambo, Professor John Lavis, and Professor Göran Tomson. I'm grateful to the member of the panel, the examination panel, for accepting to judge this dissertation. Madam President of jury, permit me to thank all those who have consented to become key informants for this research and to acknowledge all those funders, employers, colleagues, and relatives who provided invaluable support for its completion. This dissertation is documenting the climate for evidence-informed health system policy making, the development of and the influence of two pioneer knowledge translation platforms hosted in government-affiliated institutions in Cameroon and Uganda, namely EVIPNet-Cameroon and REACH-PI-Uganda, on health system processes to achieve the Health Millennium Development Goals. It investigates the linkage between knowledge translation platform activity, research evidence use, and health system policy making. The research work and manuscript preparation happened between June 2011 and June 2017. The dissertation was prepared between June 2018 and April 2009. The Viva Voce will unfold according to the following outline. Before the introduction, I would like to clarify some of the terms that will be used. During this work, we've considered health policy as a course of action and inaction that affects the set of institutions, organizations, services, and funding arrangement of the health system. We consider health system policy to be legislative, governmental, administrative, and managerial provision pertaining to governance, financial, and service delivery arrangement. And we consider health system policy making to involve the authoritative allocation of value. It's about process, the manner in which problems get conceptualized and brought to the government for solution. It's made of several stages, including agenda setting, formulation, implementation, and evaluation. We consider evidence-informed health system policy making defined by Oxman and colleagues as an approach to policy decision that is intended to ensure that decision-making is well-informed by the best available research evidence. It includes the systematic and transparent access and appraisal of evidence as an input in the policy-making process, particularly at the following steps: problem clarification, option framing, and identifying implementation barriers and strategy. Knowledge translation is defined according to the World Health Organization as the exchange, synthesis, and effective communication of reliable and relevant research results. The focus is on promoting interaction amongst the producer and users of research removing the barriers to research use, and tailoring information to different target audience so that effective intervention are used more widely. Knowledge translation platforms are a network of individuals and institutions to foster research evidence uptake in health system policy and practice in order to improve the health system performance. They are considered by some as collective efforts to ensure knowledge transfer and exchange. They are also considered as a third community operating on the problem-solving or policy-driven and interactive/social model of policy making. Typically, knowledge translation platforms prepare evidence brief for policy and convene stakeholder dialogues, run rapid response unit, and administer clearinghouse for policy-relevant evidence, and build capacity of stakeholders to demand and use policy-relevant evidence. During the last 20 years, fostering evidence-informed health system policy making in low and middle-income countries has been a priority for national and global health players attempting to bridge the no-do gap that undermines progress towards effective, equitable, and resilient health systems. They are deemed trendy efforts that bring together health stakeholders for evidence-informed deliberation, decision and policy and practice on health system. There are dozens of such initiatives in Africa, America, and Asia. The premises underlying efforts to foster evidence-informed health system policy making and knowledge translation platforms is that improving the value of research evidence during health system policy making will create and sustain the desirable conducive environment for equitable, effective, and resilient health system and services on the one hand, and will yield positive public health and social impacts on the other hand, especially in the domain targeted by Health Millennium Development Goals and the subsequent Sustainable Development Goal. Yet, there is a dearth of empirical evidence on the climate for evidence-informed health system policy making, the development of and the actual influence of such initiatives in sub-Saharan countries, which are settings where policy making is reputedly much more opaque and less studied than in the democracy within which the model were developed. The specific aim of this research was to assess the change in the climate for evidence-informed health system policy making in Cameroon and Uganda, to understand the genealogy, the development, and the breadth of operation of these two knowledge translation platforms, and to assess the policy influence of EVIPNet-Cameroon and REACH-PI-Uganda as a whole on the climate for evidence-informed health system policy making and the health system policy making for the health MDGs, especially pathway of influence and the intersection with contextual national and external factors that affect the update of research evidence. The three research questions we seek to provide answer were the following. What change have occurred in the governmental discourse related to evidence-informed health system policy making during the period 2001-2012? How pioneering knowledge translation platform emerged, and what is the breadth of their operation? Thirdly, whether and how knowledge translation platform influence national climate for evidence-informed health system policy making and health system policy making to achieve the Health Millennium Development Goals. Arguing from the analysis of scholarship on knowledge utilization, policy community and networks, policy-oriented learning and conflict and agenda setting, most scholars admit that the policy influence of research evidence typically involves the following main domains: expanding policy capacity, broadening policy horizon, and affecting policy decision. Therefore, the impact of the knowledge translation platform is expected to be double the actual influence on decision and substantive change in the general climate for evidence-informed health system policy making. Equally, the scholarship on knowledge translation strategy consistently underscored the enduring lack of rigorous and appropriate methods for its impact evaluation. Conducting such evaluation required theoretical guidance and empirically tested methods and tools that are hardly needed. Yet, then our decision to develop a knowledge translation platform analytic framework. The framework we developed as part of this research comprised two parts. The part one is a framework, a descriptive framework, comprising a table with 5 columns on function, domains, activities, outputs, and targets for influence. And as function of a knowledge translation platform, we have the capacity building, the knowledge management and linkage and exchange, and then several domains, and on the right hand, the target of influence. The second part of this platform unfolds as a logic framework comprising 3 interconnected boxes. The first box is featuring the driver of policy making, typically the institution, understood to be the structure, the legacy and policy network, the interest, the idea, including values and research evidence, as well as external factors. On the box, the second box interconnected to the first is the knowledge translation platform activities, including processes and products that would then combine to have an influence on policy making in terms of processes, in terms of decision, but also on the climate for evidence-informed health system policy making. This framework is providing an answer to the need for conceptual framework to evaluate the effect of knowledge translation platform. In this work, we've operationalized this knowledge translation platform by using interconnected steps to better understand the knowledge translation platform considered as social innovation. We've combined the description of the relevant contextual feature, meaning the climate. We've analyzed the genealogy and breadth of operation of knowledge translation platform, and we've evaluated the actual and perceived influence of this knowledge translation platform on policy process and decision and the climate. We've used the following design. We opted for a case study design, admitting that health systems are complex adaptive systems, because we wanted to have an in-depth understanding of the contextual feature of health system policymaking, the operation of this knowledge translation platform, but also to comprehend the influence of this knowledge translation platform on health system policymaking processes. We therefore consider a multiple method design, including a structural review of governmental policy documents to depict the change in evidence-informed health system policy making discourse over a 12-year period before and after the establishment of EVIPNet-Cameroon and REACH-PI-Uganda in 2006. The second step was an historical comparative case study of the genealogy and scope of actors, activity and resources of these two KTPs. And finally, a qualitative embedded comparative case study of the influence of this KTP on 4 health system policy process aiming to achieve health MDGs and the general climate for evidence-informed health system policy making. The case selection and the study context. We did a purposive selective selection of EVIPNet-Cameroon and REACH-PI for several reasons. The secretariat leaders were championing evidence-informed health system policy making. They were known to have established policy issue networks, and they have intersection with the global push for evidence-informed health system policy making and global health funding opportunities. The case selection for health policy processes was based on knowledge translation platform activities in terms of evidence-brief and stakeholder dialogues, and we set a time frame for 3 years after the stakeholder dialogue so we can describe what has been the influence. And finally, in terms of study context, Cameroon and Uganda have several similarities. First, they've been hosting this knowledge translation platform since 2006. They have similarities in terms of political system, in terms of economic development level and policy. They have similarities in terms of the tier, mixed, and poorly regulated health system, as well as the commitment to strengthen the national health research system. We've used three main sources of data. First, the documentary review in terms of health sector, national development plans, grant application to global health initiative, poverty reduction strategic papers, archives of the two knowledge translation platforms, the memo and meeting reports, as well as a survey of the PubMed. We've also used key informant interviews and the insider perspective to provide critical reflection on the process. In terms of ethical consideration, the proposal was approved by the Higher Degree Research and Ethics Committee at Makerere University College of Health Science and the Ministry of Public Health in Cameroon. Key informants signed informed consent form, and most informants were interviewed at their convenience at the right and with the right to choose to be recorded or not. During this research, the risk was minimal. We could have noticed some stress from the key informant interview. The key informant, as they were still in office for some of them, but we took all the necessary measures to protect their confidentiality and privacy. We also had some ethical dilemma, especially having some civil servant trying to alter the actual course of events, or having fears to be disseminating findings on effective use of fiscal resources, or eventually unveiling illegal conflicting interests. Our result. In the next session, we will summarize the three published peer-reviewed papers in the order that they were published and developed. Paper 1 is entitled Climate for Evidence-Informed Health System Policy Making in Cameroon and Uganda Before and After the Introduction of Knowledge Translation Platform, a structured review of governmental policy document. It is an analysis of change in the climate for health policy making in relation to the use of research evidence in Cameroon and Uganda, published in Health Research Policy and System in December 2014. As the first sub-study of this doctoral research, it set the context for a later study. The data collection and analysis, manuscript preparation, and the final editorial revision happened between June 2011 and November 2014. The scarcity of empirical data on African countries' climate for evidence-informed health system making, and the long-standing reputation that research evidence was not enough value by policymakers has justified this work, whose objective was to assess whether and how change have occurred in the climate for evidence-informed health system policy making before and after the establishment of two knowledge translation platforms housed in government institutions in Cameroon and Uganda. The design was a concurrent exploratory mixed method where we combine quantitative exploration of the user statistic of research-related work and construct citation of type of evidence and budget allocated to research-related activity, combined with an interpretive exploration using a deductive thematic analysis approach to uncover change in the institution, interest, idea, and external factors displaying the country climate for evidence-informed policy making. We've used descriptive statistics to compare quantitative data across country during two periods, 2001-2006 and 2007-2012. In terms of result, we've analyzed 54 documents, including 33 grants approved by Global Health Initiative. We notice an instrumental use of varied forms of data, information, or research to describe the burden and determinant of poverty and health condition. We also noted the sparse use of evidence synthesis to frame poverty and health problem, select strategy, or forecast the expected outcome over time and across country. Usage statistics of research-related words and construct show an increase over time across the two countries. On this figure, we illustrate on this graph how the usage statistics have evolved. On the right, on the left, we have Cameroon. On the right, we have Uganda, and the numbers represent the number of citations. And on these figures, we have four main concepts in each quadrant. On the upper right hand, it's data in health sector strategic papers, in national development plans and grants. On the right down quarter, we have evidence in grants, in national development plans, and in health sector strategic paper. And then on the left down, we have research, and on the upper left, we have value of research in this same document. The graph in blue represents the first period, and the one in red represents the second period. We will notice in Cameroon that there has been an increase on the value of research during the second period, while we'll have a consistent increase on the usage in Uganda on the red graph mostly. And we can also notice that the numbers were higher in Uganda, with the highest being almost to 150 in the national development plans, where the highest was in Cameroon in the health sector strategic paper. In terms of budget for research has increased over time with a 335% increase in Cameroon and 155% in Uganda, with most of the resources allocated to health sector performance monitoring and evaluation. When looking at the expenditure per capita, it has moved from $1.8 to $5.6 in Cameroon, $1.4 to $1.8 in Uganda. This study has demonstrated that there was a nascent conducive climate for evidence-informed health system policy making, boosted by the problem-solving approach to poverty reduction and health system policy making, planning and programming, but also by mechanism of cohesive policy transfer through standardized requirement for global health initiative grant application, and equally by the multifaceted global push to achieve health MDGs and to foster evidence-informed health system policy making, which led to the establishment of EVIPNet-Cameroon and REACH-PI-Uganda. The second paper was entitled Initiative Supporting Evidence-Informed Health System Policy Making in Cameroon and Uganda, a comparative historical study. This historical comparative case study of EVIPNet-Cameroon and REACH-PI-Uganda is the second stop study published in BMC Health Service Research in December 2014. Having examined the climate for evidence-informed policy making in Cameroon and Uganda in the first study, the second sub-study provides the historical account and critical analysis of genealogy, the actors, the activity and resources of two knowledge translation platforms that were developed to improve the climate. The data collection and analysis and manuscript preparation and final editorial revision happened between June 2011 and November 2014. This paper was justified by the scarcity of empirical data on emergence and development of institutions devoted to knowledge brokerage and their operation. The objective was to describe two pioneering knowledge translation platforms supporting evidence-informed health system policy making in Cameroon and Uganda since 2006. We use a comparative historical case study using multiple methods, a descriptive documentary analysis for a narrative historical account, an interpretive documentary analysis of the context profile activities and outputs inventory of the knowledge translation platform, as well as evaluative survey of stakeholder exposed to evidence brief for policy produced and stakeholder dialogue organized by both KTPs. Typically, we conduct a qualitative, descriptive, and interpretive archival review of EVIPNet-Cameroon and REACH-PI, and a structured documentary review of poverty reduction and eradication strategic paper, as well as health sector strategic paper produced in Cameroon and Uganda during the period 2001 to 2012 to capture the political, social, and economic context and salient features of both health systems. We equally extracted relevant data featuring the context, the institutional arrangement, the activity, and the output of both knowledge translation platforms. We've used the data of an evaluative survey that was administered through questionnaire to stakeholders who attended stakeholder dialogues in Cameroon, organized in Cameroon in these two periods, in order to help us depict how helpful each of the features of the brief as well as the dialogue were perceived, and the item based on theory of planned behavior to know how they will act following their attendance to the dialogue. We use descriptive statistics as well as constant comparison to understand, to analyze our data. What we've learned from these methods in terms of resource was that EVIPNet-Cameroon and REACH-PI-Uganda were established as demonstration projects informed by existing theoretical frameworks and were guided by a monitoring and evaluation framework that has enabled this description. Knowledge translation platforms were conceived as problem-solving enterprise operating under the learning through doing principle and have benefited from the same technical and scientific support from EVIPNet resource group for their operation, including grant writing, developing and testing new resources and tools for evidence-informed health system policy making. EVIPNet-Cameroon Secretariat operates with a multidisciplinary group of part-time researchers in a teaching hospital linked to the Ministry of Health. REACH-PI-Uganda Secretariat operates with a smaller team of full-time staff in a public university. Most of the financial resources were from external health development partners to scale up capacity building, knowledge management, and linkage and exchange activities. In terms of output, between 2008 and 2012, 15 evidence briefs were produced, 12 in Cameroon, 3 in Uganda. In 2012, 6 rapid evidence syntheses in response to stakeholder urgent need were produced in Cameroon, against 73 in Uganda between 2010 and 2012. Actually, Cameroon learned from the experience in Uganda. 10 policy dialogues were organized in both countries, 7 in Cameroon and 3 in Uganda, informed by pre-circulated evidence brief. Most of them were well received, and both KTP contributed to the development of and testing of new resources for evidence-informed policy making. Leading researchers from Northern University linked with African researchers to boost the impetus for evidence-informed health system policy making, developing and testing new resources and tools to popularize knowledge translation activity across Anglophone and Francophone Africa. They've equally opened new space for evidence-informed deliberation on priority health policy issues related to MGTs. To conclude, these were social experiments featuring the influence of policy learning and policy diffusion in the establishment of policy network and epistemic community. We've demonstrated that there were convergence. We demonstrate how the convergence of local and global factors and agents enable in-country efforts to support evidence-informed deliberation on priority health policy issues. And these policy issues, this paper actually laid the ground for the further work to assess the influence of EVIPNet-Cameroon and REACH-PI on the climate and specific health processes. This was done on paper 3. This embedded comparative on paper 3 that was entitled Assessing the Influence of Knowledge Translation Platform on Health System Policy Process to Achieve the Health Millennium Development Goals in Cameroon and Uganda, a comparative case study. It is the first and final sub-study of this doctoral dissertation. Having examined the climate for evidence-informed policy making in the first study and provided a historical account and critical analysis of the genealogy, the actors, activity, and resources of the two pioneering KTPs. This study built on this insight and then extend the analysis to provide an understanding on the pathway and actual and perceived influence of the two platforms. The data collection and analysis, manuscript preparation and revision based on 2 rounds of peer review were conducted between November 2014 and June 2017. The objective of the study was to assess whether and how two knowledge translation platforms, EVIPNet-Cameroon and REACH-PI-Uganda, have influenced health system policy making process and decision aiming at supporting achievement of the Health Millennium Development Goal and the general climate for evidence-informed health system policy making. The 3 questions were whether and how and under which condition the knowledge translation platform have influenced the policy process and decision, what were the specific impact, and what was the perceived impact on the climate. It was an embedded comparative case study of 4 policy processes in which EVIPNet-Cameroon and REACH-PI were involved between 2009 and 2011. The 4 policy processes were scaling up malaria control in Cameroon and improving health district governance, while in Uganda it was on task shifting for optimizing the use of human resources and skilled birth attendance in Uganda. As data source, we use documentary review, semi-structured interviews, and insider perspective. The data analysis was based on framework guide thematic analysis using the analytic framework that we've developed. In terms of result, the KTPs had direct influence on health system policy. We had go-ahead, no decision, and status quo decisions. Decisions were reached when a policy entrepreneur sees the opportunity to align the priority health problem with stakeholder consensus, palpable during dialogues, and affordable policy option and related implementation consideration suggested in the evidence brief. Typically, the co-production of evidence brief combined with the tacit knowledge gathered during the inclusive evidence-informed stakeholder dialogue concurred to facilitate the decision by the policy entrepreneur by reframing health system problem, unveiling source of conflict, opening ground for consensus, and aligning viable and affordable options to achieve the health MDGs. We've observed an emergence of new health policy issue network. The process leading to this inclusive safe harbor evidence have altered contextual factors, especially policy network issue, interest group interaction, and prominence of evidence-based idea, and contribute to enhance health governance and equity, as well as to strengthen democratic processes. Knowledge translation platform indirectly influence health policy process by changing how interests interact with one another, intersecting with contextual ideational factors, but also improving access to policy-relevant evidence. They were perceived as change agents by the positive impact on the understanding, acceptance, and adoption of evidence-informed health system policy making, but also by the complementary and synergistic effect relating to capacity building activities, rapid evidence synthesis, and clearinghouse of evidence-informed policy making. Most stakeholders were very appreciative of and supportive of the knowledge translation platform because they've enhanced the access to relevant evidence and have empowered civil society representatives, including the media, to demand access and appraise relevant evidence and to further articulate the advocacy campaign views and expectations. In conclusion, EVIPNet-Cameroon and REACH-PI-Uganda influence the general climate for evidence-informed health system policy making and policy decision through pathways involving policy issue network, interest group interaction, and evidence-supported ideas. At this juncture, we'll move to our general discussion. This dissertation as a whole is a theoretical, methodological, and substantive contribution providing answer to the methods and knowledge gap identified at its inception in 2011. As theoretical contribution, we've presented the knowledge translation, the KTP at 3I+E framework that is combining health policy analysis and political science variable and interactive knowledge translation perspective. It combines a descriptive framework and a logical framework, and it's furthering two existing framework to assess country effort to link research to policy developed by Lavis in 2006, and the one by Ward to describe the constitutive function of knowledge brokerage enterprise. In terms of methodological contribution, we've adopted a critical realist sense with a system thinking lens, and we've developed an interconnected three-step cross-country case study design using multiple methods. First, a concurrent exploratory mixed method for content analysis of governmental policy documents. Second, a comparative historical case study using multiple quantitative and qualitative methods for historical tracing of EVIPNet-Cameroon and REACH-PI-Uganda. And third, an embedded case study using qualitative method for process tracking of 4 health system policy process, combining documentary review and semi-structured interview with key informants selected after stakeholder analysis and contribution mapping. In terms of substantive contribution, multifaceted empirical evidence has been produced on the longitudinal change on climate for evidence-informed health system policy making in Cameroon and Uganda, on the governance of national health development effort, especially the influence of external agents and factors on civil society participation to health policy debate, and the integration of equity consideration, the breadth of the operation of EVIPNet-Cameroon and REACH-PI-Uganda, the pathway of influence of both knowledge translation platform, the actual and perceived influence of both KTP as a whole on the climate for evidence-informed policy making and health system policy process and decision. 5 key elements. Climate for evidence-informed health system policy has improved in terms of discourse, resource allocation, and stakeholder perception. EVIPNet-Cameroon and REACH-PI-Uganda emerged as pioneer knowledge translation platform embodying the global push for evidence-informed health system policy making triggered by the 2015 development agenda. Knowledge translation platforms have been instrumental in reinforcing the conducive climate for evidence-informed health system policy making. We've noticed the intricacy of politics and organizational/individual factors pertaining to research to policy interface. We've noticed cohesive policy diffusion through global health initiative. and knowledge translation platform have direct and indirect influence on for policy making through pathways of interest group interaction and research-based ideas. This work has some limitation. Most of these limitations are linked to the methods, the time frame, the recall bias, the rewriting of the history, and the restrict access to source of political information. But the interconnected three-step cross-country case study design help us to mitigate some of these limitations, as some of the weaknesses of the first study were complemented by those of the second and the third study. This research have implications for policy and practice. First, evidence synthesis need better consideration. Efforts toward evidence-informed health system policy making through knowledge translation platform warrant further support. Critical consideration for actors developing knowledge translation platform in low and middle income country are the consideration of the coordinating mechanism in place, promoting fair participatory process, need for committed and skilled human resources, and the co-production of evidence brief. We also notice that there are changes needed in regulation and incentive for health system and policy making by creating institutionalization mechanism. There are 4 implications for future scholarship. The KTP at 3I+E framework should serve as a starting point for comprehensive examination of knowledge translation platform. Knowledge translation platform are critical agent for contextualizing health system guidance developed at the global level. Scholarship on health governance should incorporate performance indicators pertaining to the functioning of such initiative. And there is a need for further investigation of the interdependency of emerging policy network and to explore the national global interface to better comprehend the supranational influence on health policy change, especially the coercive policy transfer and diffusion mechanism. To conclude, this dissertation is a landmark to the scholarship of the influence of knowledge translation platform in sub-Saharan countries. The analytical framework and related multiple methods designed shall inform future scholarship investigating the country-level climate for evidence-informed health system policy making, the genealogy and operation of KTPs, and their influence in polity similar to Cameroon and Uganda. Robust, multifaceted empirical evidence that KTP warrant further support from national and global health players aiming to strengthen health system within the framework of universal health coverage and sustainable development goals. EVIPNet-Cameroon and REACH-PI-Uganda have influenced positively policy process and decision relating to health MDGs through pathway involving policy issue network, interest group interaction, redistribution of power resource, and evidence-supported idea, all within prevailing political arrangement for health system policy making. Thank you for your attention.
Extensive thesis that has been all seen addresses an important area in terms of the methods and processes in evidence-informed policy making. Just before I move on, I hope everyone is able to view my screen.
Yes, we can. We can hear you loud and clear.
Okay, thank you for confirming. So in terms of maybe a number of areas that I thought we could explore further, particularly regarding how we could move some of the tools and the methods and the platforms that are described in terms of helping act on evidence to strengthen health systems, particularly in sub-Saharan Africa. But just before that, just to acknowledge that this is quite an extensive work. You explored a diverse range of methods and processes in evidence from policy making. using multiple methods spread across the 3 studies that we described. There were quite some aspects that I thought probably you could clarify further, particularly in terms of how the 3 analytical frameworks really anchor the main subject of this thesis, that is supporting evidence-informed policy making. Specifically, could you describe or expand more that underpins the 3 studies, with particular regard to the theoretical thinking that underlie that conceptual framework, and how the 3 studies that you described contribute and link to each other to inform the overall conceptual framework?
Okay. Thank you very much for your question. The development of the framework was informed by a narrative literature review of the scholarship following an assessment of the substantive, theoretical, and methodological gap. We've actually reviewed scholarship on policy making, on the use of research evidence in policy making, and the theoretical underpinning of knowledge translation platform, and then the extensive literature on assessing the impact of research evidence in policy making before developing and trying to combine some of this scholarship. So typically, as we've said, we've had key papers, seminal papers on knowledge translation that were published around the year 2000 as the MDGs agenda was developed, and then we have the World Health Organization report on research for better health and the subsequent policy health global policy decision made to align efforts to achieve the MDGs. So we've had seminal work by Lavis, by Green, and others looking at what could be the contribution. We have the framework by Van Kamen, the IDRC, International Development Research Center in Canada, fostering some research on knowledge translation. And we've also had several papers by from the DFID on the Office of Development Study on some of the challenge on influencing policy based on research evidence, paper by Boas, for example, in 2008, where they call for development of conceptual framework and methods to orient future evaluation of such intervention. Then building from the interactive knowledge translation model, building from the critique from policy analysis and political science, we came out with first, if we want to understand how knowledge translation platform could have an impact, we need to understand what is the concept in which and what is the triggering elements of the creation, so we can see how they've been integrated within their context, and then looking at how the several activities, all the intervention for reducing the barriers towards research utilization will be managed to achieve the purpose. So we thought by having first an understanding of what was going on, to be sure that research evidence was or were not being used in both countries, We can also know typically what these knowledge translation platforms are doing, because they are embedded within government where there were some political decision to support and strengthen the national health research system. We can then later on look at specific processes. So overall, the three-step progressive approach has helped us to consider that the political science or policy analysis scholarship on how people come to decision has been demonstrated by these two initiatives. So the first study is setting the ground to understand what is the context for evidence-informed policy making beyond the health sector domain. The second actually look at what the two knowledge translation platform were doing. What was the logical model for generating influence? And lastly, the study actually tried to close the loop. The third study tried to close the loop at looking at specific policy process that these two knowledge translation platforms have engaged into with the purpose of boosting the achievement of health Millennium Development Goals.
Thank you for that clarification. Then move on to your second paper where you describe the two knowledge translation platforms, that is EVIPNet-Cameroon and REACH-PI in Uganda. So in this study, you explored knowledge brokering using comparative case studies of PhDs Cameroon and Uganda, and employ mixed methods that you described as descriptive and interpretive document analysis. You do mention about some of the limitations in your discussion of results, but I wondered whether you could, in terms of fostering the use of knowledge translation platforms, and particularly the findings that you report, whether there were any limitations of this methodology and how they could have impacted on our confidence in the conclusions that you make.
So, the main limitation of study 2 will first be the design. We've actually decided to describe what was, to describe the archives of this two knowledge translation platform. And by doing so, we have probably missed the individual factors or the informal connection that have existed before it, because we were mostly looking at what was written in the archive. So this will probably this is probably missing, and we couldn't capture, because for this first study we didn't ask questions, we didn't have interviews, but we've managed for the last study to have some questions to better understand how come these were developed. The second was the second limitation is probably that we didn't capture the external actors' influence. As we've said, the two secretariats were interacting with global players, and they got funding from external donors, and we were unable to capture the very reason of the funding process, and this probably is missing. So we can't capture the views and perspective of these external players, especially funding agencies. Lastly, the insider narrative could be a source of recall bias or probably some social desirability with a negative effect on neutrality and objectivity. But the supervision team, and we've strived to be as objective as possible, and this was, we've also used triangulation of different sorts of documents, as well as in the last study we have key informant interviews where we first had the stakeholder analysis and the contribution map to get to those who were involved from the beginning, so we can capture different perspectives. So overall, this limitation I don't think are deleterious for the validity of the result. As we were writing the history, we are probably missing some of the other perspective, that is the external perspective, but we've managed to capture both the internal and the written part of it.
Thank you for the clarification. You mentioned quite a number of attributes of the knowledge translation platforms. Talked about the resources that were incurred, the budgets, which looked substantial. I mean, with this background, do you think to what extent are the platforms, the EVIPNet and REACH-PI-Uganda, generalizable to other low middle and income countries?
We already have cases where other countries have used the model developed in Cameroon and Uganda, and we've made suggestions to those interested in developing knowledge translation platform. The problem-solving perspective and the contextualization is critical. Typically, because of the infrastructure in place, this model can be replicated, but they have to be based on stakeholder needs. It can't be imposed from outside. The idea has to meet with a local need. So stakeholder consultation and engagement is critical to help it, to enable the cross-fertilization between the researcher, the policymaker, and civil society group. There are a lot of different models mushrooming currently in Africa, in Asia, and the America. And most of them some of them will be within a government affiliated institution, but some will also be outside of government affiliated institution, being organized by civil society group as well.
Okay, thank you. And now coming to the rapid evidence synthesis that were again produced in your study group. So specifically, there were 6 rapid evidence syntheses in response to stakeholders' urgent needs in Cameroon, and 73 were produced in Uganda. What was not clear in the thesis was really the methodology or the concept around the rapid reviews. Could you elaborate on this and how this sort of evidence summary formats
okay.
usability of summarized evidence?
Okay, thank you very much. Typically, the concept of rapid response or rapid evidence synthesis is the concept of providing within 2 to 4 weeks answer to an urgent question raised by a decision maker. So the first step will be the policymaker has a question, then he asks his question, and we have a process of clarifying the question where he interacts with one of the officers of the knowledge translation platform. Some question will be around, are there any effective intervention to improve the usage of telemedicine in low and middle income country? Then the research officer at the knowledge translation platform will look for framework or for systematic review to see if there are any, and will present a summary of this type of evidence. It doesn't go beyond this if there are framework or systematic review, so it will be a rapid, the answer will be yes, there are effective intervention, this is what evidence tells us, and the decision maker will be provided with just this information. In some cases, there could be some reflection on the contextualization of this evidence, how applicable will be the evidence. But when it's about a question, let's say a question for a cabinet meeting, is it worth changing food or regulating food additives? So again, the interaction between the research officer and the decision maker will help clarifying what are the expected results, so as to target the response to the need. And there are tools that have been developed, available online on how to proceed. These tools were developed by the SHORE project. And it's quite different from the rapid systematic review standard being developed by Cochrane. The one on SHORE is typically providing a short answer to a decision maker or a minister going for a cabinet meeting, or a commissioner going for the top management meeting.
Thank you for that clarification. And I just wondered whether there were any methodological challenges that were encountered in both Cameroon and Uganda in terms of responding to the urgent policy needs through the rapid evidence synthesis.
There are several challenges, and one of my colleagues in the doctoral study program has been working in depth on this rapid evidence synthesis, Dr. Rona Mijumbi. Some of the challenge were around the whole process of clarifying the question, and then finding evidence when there is none in terms of systematic review, or when it's just primary studies. And again, the interaction somehow could be bothering for the decision maker who is expecting you to provide an answer in 48 hours, but it needs to be explained to avoid conflict.
And in terms of keeping the evidence synthesis up to date, are there any plans for a formula update of the summaries that were produced?
As from now, some of the evidence synthesis were revised upon request. Typically, the reasoning was problem solving. When stakeholders raise the issue, they are provided with the available evidence. now, as they move to the decision, they could raise other questions, and then it will move further. So there is no systematic process for updating the evidence, as it's a synthesis of different type of evidence available when the problem was raised and when the decision were being prepared. Until now, back home, we haven't revised any of the evidence synthesis as the decisions were made and other questions were raised by policy makers.
Oh, thank you for that, and I hope in light of that statement, perhaps in the evidence summaries, we have information on when the searches were done for the evidence that is included in the synthesis. And still related to the evidence summaries, and in particular the design features of the evidence briefs. In one of the tables in paper 2, you mention a number of attributes of optimal information design features for the evidence summaries of the briefs. One of them is the quality assessment, but what's not clear is the approach that was used for the quality assessment summarized in the evidence briefs. Could you elaborate on this?
Okay, so as this project were a demonstration project, and there is a global network of those working on preparing evidence brief, there are mechanism of there is a standard model for brief, and then most teams are advised to, once they've prepared the brief, to seek for external review. And the method has suggested by the EVIPNet Global Resource Group, and typically some of the evidence in Cameroon will be reviewed by a content expert in Cameroon or elsewhere, and then the quality assessment will be requested from somebody who have a lot of experience writing evidence briefs. So we've had interaction across the country, some evidence brief being reviewed in Cameroon coming from Zambia, or some from Burkina Faso, and so on and so forth. So the process was a collective learning process with standards that were clarified. We have a framework for preparing the brief with some recommendation on how to appraise evidence, how to include the evidence, and after the preparation, we set an external review process, a voluntary external review process.
But was there any specific quality appraisal tool that was used to assess the studies?
So typically we will give science to systematic review, and then we'll use the grade assessment. We also use the AMSTAR to assess the quality of the review being integrated in the evidence brief. We've also been using other criteria developed for primary study when we didn't have a systematic review. So typically the AMSTAR for the quality of the systematic review, then the grade for the certainty of evidence, and more recently we've been using the grade ATD from grade to decision that has been developed by the international group on grade.
You also point out that one of the features employed in the preparation of the evidence briefs was the so-called graded entry summary format.
So typically this was imported for the grade entry is the 1-325, that is 1 page of key messages, 3 pages of a structured abstract, and the 25 pages for the full report. The idea being that you should have this handy 1 pager for the minister or the high, and then the 3 pages for the senior, and then the 25 pages to have the full evidence document. And usually some of the evidence brief went beyond the 25 pages when the evidence was, the available evidence was quite rich.
And have these formats been tested to provide evidence that they actually improve access
So
to
as part
stakeholders?
As part of the SHORE project supporting the use of research evidence in African health system policy, we had a user assessment study that actually where people, as we were developing this, where we needed feedback from users. So typically, the 1 pager were very appreciated by the senior, the busy guy on the top, and then the full and the 3 pages were also handy for those assisting them as they could go further in the discussion. And when we moved to the dialogues, some of the technical officers were very happy with the full report, as it helped them actually figure out what they could get further. And it had also been helpful for some of those faculty members. Evidence gap were identified, and this has served as entry point for new primary studies.
And in terms of this survey that you conducted around these evidence summaries, of course most of the stakeholders had positive responses, but in particular they expressed lower satisfaction with the fact that the briefs did not include or conclude with any recommendations. Could you explain why the evidence briefs should not include recommendations?
This has been a debate at the initial phase, but as from now, it was a good idea not having recommendation. The evidence brief is meant to inform all stakeholders on a priority issue, so that they will use evidence based on their own standpoint. It will be difficult to come out with recommendation while you are preparing a brief that need to be inclusive. You have civil society coming in, you have private actors coming in, you have several cabinet department coming in, whose recommendation, for the recommendation to be clearly established, you need to know what is the decision. But the point here where we need to stay open enough, and the researchers shouldn't interfere with the stakeholder position and those at the end of the day who have to make decisions. So we needed this brief to inform deliberation of stakeholders, not to have researcher recommending something, so that we open space for a democratic process among health stakeholders.
And still on the evidence briefs, what is not clear really is how potential intellectual conflict of interest were addressed. Was this something that you considered during the preparation of these briefs?
On the guide on preparing brief, we've asked for a statement on conflict of interest, where people needed to set the background, the context of how this brief was written, and then who has funded the preparation of the brief. And typically, what was recommended was to have a co-production process, that is having a scientist and a decision maker, the problem owner within the given ministry or the given department, to sit and write together the evidence synthesis, so they will combine both the administrative data and research evidence. And they had to be clear on what were their position.
Yes, and linked to that, in terms of the policy deliberative dialogues, was this also addressed before the deliberations on the topics that were covered in the evidence briefs?
So typically, those who were convened to the stakeholder dialogue were convened following a stakeholder analysis, and the convener for the dialogue will typically be the problem owner within the given department. And because they knew that this civil society group is working on this particular topic, or this professional union is a key stakeholder, is a key player, they will be invited. So typically people will know each other's standpoint as they are sitting during the deliberation. No one will hide, actually, and people were allowed to, as the process of deliberation were organized, the deliberation actually look at the evidence, what were the underlying factors helping to have a better understanding of the problem, and then when it came to the evidence, people were asked to reflect on how applicable, how feasible, how pragmatic or realistic was it to consider this lesson from the evidence summary, how they will apply it to their own context. So participants actually knew who is who in the room, and the dialogue were organized under safe harbor condition, applying the Chatham House rule, helping people to feel free to express their, and the report from the dialogue will never cite who have said what during the dialogue.
Okay. I mean, still on the EVIPNet and REACH-PI policy dialogues, one outstanding strength of the platforms was the involvement of multiple stakeholders, that importantly included groups that are traditionally not involved in these policy processes. For example, in Cameroon, there was involvement of the Cameroon Coalition Against Malaria Parliamentarians Network and the Cameroon Media Against Malaria. In both countries, there was involvement of the Association of Women Members of Parliament. I mean, from your experience convening and running these platforms, what are the challenges to involving parliamentarians, elected leaders, and the media in evidence-informed policy making?
Okay. To start with the involvement of parliamentarians, they are too busy. They are too busy. It was hard having some of them, but once you've identified when you've conducted a comprehensive stakeholder analysis, you come to realize that within the parliament, there are subgroups of parliamentarians working on some issues, and once you knew about them, it was much more easier to get to the focal point because they've already expressed their interest in a given topic. Again, the media was involved as an organized group, not individual journalists coming in. It was those who were organized with a clear objectives. When we refer to the Cameroon Media Against Malaria, this is an association who was established and decided to support the fight against malaria. So when we invite them as a representative of a civil society organization, not as an individual. And at some point, it was clear, because by accepting to sit during the stakeholder dialogue under the Chatham House rule, the representative of the media is morally engaged not to break the rule. So this has been the way we've proceeded. I should confess it has not always been easy to have parliamentarians attending the dialogue.
And do you have any proposals on how we could optimally engage these two groups to promote action on evidence-informed policies?
Typically, the solution that we've been using, and as we move forward, we consider is a best practice, is actually to conduct a stakeholder analysis within the parliament and go and try to learn and understand who is supporting, who is sitting in which committee, and if they have a subgroup within the parliament, try to see what they've done so far, so that you can identify what are the topical issues. And equally for the media, we should mostly deal with organized group of media to bring them on board. So you need to conduct a comprehensive stakeholder analysis to keep them on board and maintain them on board.
And maybe lastly, in terms of the actual resources, goods, activities that came out of these projects, I wondered how this could be scaled up in other low and middle income countries to support informed policy making, and whether there are any plans to do this.
EVIPNet Evidence Informed Policy Network is an initiative by the World Health Organization, and there is a team, a resource group and a steering committee that is still running, offering most of the resources are on their website at WHO. But in Cameroon and Uganda, there are clearinghouse where some of the documents and the resources are published. There is also the McMaster group, the McMaster Health Forum, and in most regional offices of the World Health Organization, focal points are in place to support countries who want to move forward establishing this type of platform. So there were lessons learned were published, and when we look at the current strategy on the African region to promote evidence-informed health system policy making, knowledge translation platform are being promoted, and some new countries were exposed to such initiatives.
But do we have capacities at the country levels to, for example, be able to produce the evidence briefs that were prepared within the EVIPNet and REACH platforms?
The capacity, looking at a critical element is actually having higher health education institution. If we have people with skills in policy analysis and critical appraisal of systematic review, and people willing to collaborate, the tools that have been developed are really step-by-step processes, and the resources that have been developed during this whole process are some of them have already graduated as PhD and are working on position. There is a knowledge translation unit within Makerere. There are others across the continent. The resources are available now. What the human resources are available, but it's also a learning by doing process. And finally, the critical element will be the funding and the political willingness of opening space for evidence-informed deliberation on health policy issues across the continent.
And finally, how could these approaches be applied in the development of public health emergency guidelines, and in particular whether there are any adaptations that could be made, for example, the timing and format of the evidence summary briefs, or the sort of stakeholders that could be involved to provide a timely response to disasters or emergencies, for example, COVID-19.
I will take the example of Cameroon, where the center, the EVIPNet-Cameroon has been used to prepare some work, but under the Scientific Council for Public Health Emergency, where we have a multidisciplinary group of experts, and then the EVIPNet will serve as the secretary preparing some of the evidence summary that will be then discussed and shared with the government. Now, is it possible to have adaptation? Typically, when the secretariat is established, we just need questions to be raised, because they have been trained for knowledge brokers, they've been trained to provide a handy, user-friendly format of evidence. They can do it under the rapid response unit process that will help providing evidence synthesis based on the urgent matter to be addressed.
Thank you for that clarification. Just in terms of some closing remarks, just to congratulate you on this work. It's a major academic achievement. This is quite comprehensive, well written, and despite addressing complex topics, the concepts were well articulated, and the findings clearly have a range of applications in terms of fostering evidence-informed policy in low and middle income countries. Thank you very much. Yeah.
Thank you very much for your interaction. Thank you.
And thank you, Dr. Pierre, for this wonderful interaction and quite an educative session. Next, we'll move to the external examiner, Professor Sandy Oliver. For the next 10 minutes, you can interact with the candidate.
Thank you very much. Thank you, Dr. Pierre, for your very clear presentation of your thesis. I have 2 questions of clarification to help me locate your work in the wider literature, and 2 questions of judgment where I'll be interested to hear your views. So my first question is about your logical framework that combines knowledge translation programs, the 3 I's, institutions, interests and ideas, and external factors. And I was wondering about what these external factors are and to what extent they might be events or happenings in the way that we see external events in other theories of policy analysis, such as the advocacy coalition framework or the opening the policy window in kingdoms multiple streams, or the punctuated equilibrium theory. So to what extent are the external factors events? But I was also wondering, and this is where my head sometimes gets a little confused, to what extent are the institution's interests and ideas external, or are they actually infused throughout the whole thing? So this is a question of clarification for my benefit. Thank you.
Okay, thank you for the question. The first point on the external factors. Typically, they are related to some of the report. In this work, we've observed that the publication of the Transparency International report pointing at corruption in these 2 countries impeding development has had an influence as it make publicity, it publicizes the level of corruption and the side effects, and then it has an influence on you need to use evidence to be sure that the choices are well informed. So this has had an impact with by pushing the idea that evidence-informed decision-making will help reduce the corruption and behind the doors negotiation on selecting some of the strategies. These external factors will also be the global health initiative opportunity. We've observed, for example, that by changing the grant application guidance for global funds and requesting point on use of data, trending monitoring and evaluation has had an influence on how these plans or how the plans were written as they were connecting. So this is what we've called some form of cohesive policy transfer or diffusion. Now, when we refer to institution, they are not clear cut between some of these that are diffuse in terms of the rule of the game. Some of them are written, but some of them are not written. So we agree that the institutionalism as a scholarship is still blurred, but the idea by Kingdom or the advocacy coalition framework are of interest. But from this particular perspective, considering low and middle income country, we think that instead of using the advocacy coalition framework that mostly apply to clearly or long-standing pluralist system, the framework we've suggested here will fit better because of the looseness of the divide in the society. When we look at Cameroon and Uganda, there are several political parties, yet the president party is having the large majority in the parliament. So the advocacy coalition framework will certainly stand in pluralist, democratic, liberal system, but it won't stand in Cameroon and Uganda, for example, especially when it comes to health issue, considering the burden of disease and the burden of weaknesses.
Thank you very much. That was a very helpful elaboration. So my second question is about how your work relates to the international literature synthesized by Moat and colleagues in 2013. You mention in your thesis that you have characterized direct and indirect routes for knowledge translation platforms to influence policy. And then I got slightly confused with the argument about how this relates to the work of Moat and colleagues, where I thought, but I may be mistaken, that they were considering the reverse flow of how ideas influence the perception of evidence briefs. So I wonder if you could help my understanding here about clarifying the direct and indirect routes for knowledge translation platforms influencing policy and the reverse flow of how ideas influence the perceptions of evidence briefs. Thank you.
Okay. You are completely right that it's not an easy it's not easy to understand. But in the particular case of knowledge translation platform, the whole process of preparing a brief was already a participative process, where initially the stakeholder were engaged to identify the priority topic. Once they've engaged into the process, the decision were then made to prepare a brief because they wanted to move forward the agenda. So this was the co-construction, the co-production process actually could justify the fact that those who were exposed to this particular evidence brief were already part of it, so they own it, and this will they will come in because they are already biased toward what they want to achieve. And now, if we want to study it out of the very context of how this particular evidence brief and stakeholder dialogue were organized, then we might miss something, as a knowledge translation platform were actually conceived to be part of the process from the beginning, trying to be as inclusive as possible, building capacity and helping people to solve problems. So this will probably provide us with elements to counter the argument of the reverse flow around the evidence brief. If we don't consider the very context of how this brief that we are referring to were developed, then we might miss why people had different perspective from it.
Okay, thank you very much. So now I've got two questions of judgment. So you mentioned for the time frame for study 3, you suggested that 3 to 5 years might be a limitation given Sabati's recommendation for studying policy processes for 10 or more years leading up to decisions. So I wondered whether introducing knowledge translation platforms actually accelerates the usual processes, or whether what you were doing was focusing only on part of the story. So my question is, what in your view makes a 3 to 5 year time frame sufficient for such a study?
Okay, so we've looked at the legislative term. We've also looked at a plan of action of the platform, but also the strategic planning in both in Cameroon and Uganda. And looking at what the knowledge translation platform were involved into, we thought we need time to capture what would have been achieved, and there were also the constraint of having this work done as part of a PhD program. So typically, malaria control planning in Cameroon lifespan is 4 to 5 years. Again, the national development papers is 15 years, but we were at the end of a previous one, and there are some of the issue on the work plan of the ministry. The issue on human resources will take much more time, but the plan for improving maternal health in Uganda will be between 3 and 5 years. So we are presenting a part of the story on some of the process that were actually considered to be priority in relation to the MDGs and in which the two knowledge translation platforms were involved. That was the main reason we selected it. Definitely, it's part of the story because we wanted to understand how it has happened, and we had sufficient time to see the effect or the impact.
Thank you. That's clear. So my last question is about these 3 studies being pieces of insider research, where you and close colleagues were actually involved in developing these knowledge translation programs. You do mention it in your thesis. So can you please tell me about how your personal standpoint may have influenced your work, and what advice you'd give other scholars embarking on studies like these?
My standpoint, probably, as well as the supervisor, I've said it initially, most of us were involved in promoting evidence use and following the whole process. But we needed to identify and try to be neutral enough, as we had a lot of discussion, a lot of interaction, to capture only what was as objective as possible. I've been the secretariat, I've been the chairing EVIPNet-Cameroon, as well as the part of the global steering group, as well as my supervisors. So the idea was to look, building on different sources and avoiding to have any influence, yet the insider perspective and the social desirability will be there. But the key informant interviews were interesting for us to show how people actually perceive. And what would be my advice to others embarking in the same type of study is probably to have a comprehensive context mapping, because some of the challenge could be access to administrative documents or access to archives. I'm not sure it would have been possible for me having access to all the archives of the Secretariat in Makerere or in Yaoundé if I was not as involved as I was, or having access to McMaster archives as well. So engaging into looking at the research to policy interface, you have to work hard to have access to actors. So this will be the first. Then the second will be clear on what is it you want to demonstrate. If you want just to demonstrate that A plus B equals C, you need to look at different processes, and you need to bear in mind the political context and the time it takes to make policy, and you shouldn't be too positivist in your perspective. So typically, the critical realist stance will be the best, and probably I will add be aware of the challenge of studying policy making, the process, but also the power.
Thank you very much, Dr. Pierre. I have no further questions.
Thank you.
Thank you, Professor Sandy, and thank you, Pierre. I think it would have been better if we had a video showing the discussion. Maybe for the next presentation, Professor Göran, please you could use the video mode so that you can see the interaction. Thank you. So over to you, Professor Göran, the next 10 minutes.
Thank you very much, Pierre, for the wonderful work, very interesting work that you have done. I'll just move through my questions, not in any particular order. But first of all, I want to ask you to reflect a bit on the problem that led you to this study. Just to give us an idea of the contextual issues existing in the two countries, Uganda and Cameroon, that led you to think that there could be a problem with the use of evidence in a health system policy making.
Okay, thank you for the question. The very reason that inspired the work was that Cameroon and Uganda were lagging behind the achievement of health MDGs when we conceive of this research project. And despite the fact that they've been part of those with institution in place aiming at strengthening the national health research system. So we wanted to understand what were the issues. And when we look at the context in Cameroon and Uganda, in terms of the political environment, they were quite similar. So one would expect that if evidence-informed health system policy making was instilled in the system because of, in quote, conservatism in both countries based on the traditional ruling system, this could actually speed up the strengthening of the health system. But we also noticed that there were a divide between the politician and the researcher. This was the very justification of the idea of knowledge translation being an opportunity for bringing together most of the stakeholders. And finally, there were a lot of issue with inclusion of those vulnerable and the poverty spreading in both countries. So we thought that by bringing more rationality, we could actually help these two countries make a greater step in terms of improving the health condition of their population. They had they have the academic, they have the medical doctors, they have the resources, they have a quite stable political environment. We thought it would work easily and move smoothly.
Thank you very much for that response. Do you have any information on the number of health policies drawn, in these countries with the period of interest? For instance, where you are looking at 2001, 2012, do you have any idea on how many health policies, were drawn in this period in the two countries?
So we've looked at the health sector strategic paper. During that period, there were one in Cameroon during the period because the health sector, the health policy was adopted in 1996, but the health sector strategy was developed in 2001 and has to span till 2015. And the same was the case in Uganda, with a revision occurring during the period, if we are looking at the strategy. But there were several other policies in terms of governance arrangement at the meso level, not at the macro level. I can't give an exact number of some of these policies, but in this work we focus mostly on those who were related directly to health MDGs, looking at some of the disease-specific plans that were part of the health MDGs around maternal and child health, around HIV/AIDS and access to medicine, HIV/AIDS, malaria, tuberculosis.
I think that's been important to describe in the description of the safety, what was going on. I think I missed that in your write-up. Then the other issue is what was the basis of and this is now in relation to paper one, what was the basis for categorization of the time periods, 2001, 2006, and then 2007 to 2012?
Okay, so our reasoning was around, we were looking at the health MDGs, and the health MDGs were adopted in 2000, and we look at the year following the adoption, and we consider that following the governmental commitment to align the trust of the of the development on MDGs, we will start having elements that will reflect this commitment. And then the establishment of the knowledge translation platform were in 2006. So equally, we've said if we are looking at this 2-6 period, from the adoption of the MDGs and the creation of the knowledge translation platform, having a 2-6-year period will help us actually see if there has been any change in relation to this issue that were global commitment and the establishment of the platform in 2006 in Cameroon and Uganda. And this was also, and the 2006, because following the Global Ministerial Summit on Health Research, there were a resolution by the World Health Organization creating EVIPNet and promoting knowledge translation platform, and hence the establishment in 2006 of this pioneer knowledge translation platform.
Okay, so thank you very much. I think that needs to be clarified in right now. But continuing on that, then you chose to compare the two periods, using analysis of variance. Maybe you will comment on why, but then also looking at that comparison, you gave averages at some point, utilization of research-related clusters using averages. And I don't know whether you actually could conclude on those reasons by just using averages. Maybe you could just make a comparison, by use of averages.
I missed part of your question.
I said maybe you can comment on whether analysis of variance was appropriate, for comparison of those two time periods. So that's one. Secondly, because you seem to compare, for instance, use of utilization of research-related clusters, comparing that using averages. So I was inquiring whether that was adequate, that you could actually conclude by comparing an average in the two time periods, for the two countries. Is that adequate for you to make that comparison and conclusion on whether there are differences or not?
Okay, using the content analysis and concurrent exploratory design, we've used it as it has been the case by Hovland and others looking at analyzing media engagement in some policy, or also one by Lavis. So typically, the idea is to combine this quantitative aspect of how some of the concepts appear in the document, but also to understand and having a constant comparison in the context in terms of the content analysis. It's not the words usage or the usage statistic, is just an element to try to understand. So this is why we've combined it with the qualitative analysis, where we were actually using the constant comparison, looking at the text and the meaning and and the narratives within the document. So it was just a way of looking at the rhetoric, but also trying to understand the very textual context in which it was used. So the quantitative were to just help us unpacking the context and having a better understanding.
Okay. Yeah, thank you very much. So I would like to thought that, first of all, because we just have two time periods, I don't think that after, as we're talking about whether there will be improvement or not, you have the confidence intervals to guide whether there are overlaps and so on. But thank you for that response. So looking at the maybe the interest of time, I'll just give you mentioned you are using quantitative and then qualitative results, methods. So in some of your studies, you have the mixed methods, mixed methods. And could you just comment on how, they were triangulated, the findings or I don't know what levels you triangulate for the different methods, and how did they speak to each other? And you can give maybe some specific examples on how the quantitative and the qualitative spoke to each other.
Okay, thank you. For the comparison of the average, we've used the F-test to compare the difference in average, and we had a statistical difference. So when looking at the usage pattern of cluster of research-related words, so we used the F-test, and the difference was significant. Now, within this same study, we've used it, we actually went to look specifically on some of the section of this policy document. We have in mind, was it about framing the problem? Was it about selecting option or setting the stage for the policy evaluation? So this was the reasoning. So we went then back and looking at how some of these words were cited in the different section of the document to make sense of what was expected. Typically, one would expect that in describing the problem and looking at some of the background evidence, we will find typically surveys or data from the statistics department describing the burden of issue. But then one would expect that they will have systematic review or conceptual framework to explain and unpack the root cause of the problem. And then in identifying the option, we will expect that in some of the section in selecting the policy option, one will refer equally to a known effective intervention. So we've combined them with the background information that a policy document will actually describe the problem, provide evidence on the underlying factors, and then before suggesting the option for solution and the expected result. And this is how we've tried to, this was the guide to merge both the quantitative and the qualitative. So for example, what we've noticed was that in the National Development Plan, for example, there were a lot of references to evidence-informed decision-making as a general principle, but when it came to actually applying it to describe and identify the underlying cause of some of the poverty issue, then nothing was clearly said. Again, when the strategy to curb poverty were identified, nothing was said on the expected benefit of this strategy in terms of reducing poverty. So these are some of the examples, and this was quite true both in Cameroon and Uganda.
Okay. Thank you very much for that. Then I'd like to, you have a lot of qualitative work, and when you're looking at, maybe I'm just generally quoting methodological, you use a lot of the, what I would call the quantitative numbers, limitations. So I'll just ask you to reflect and say something about the trustworthiness of your studies.
Can you please repeat? I didn't get you clearly.
So I said that your work, you have the mixed methods, but a lot of qualitative work, and I see in yours the writing up of what I would call the methodological issues or considerations. to have a lot of the quantitative language, if I can say that. So I just wanted you to reflect a bit on the trustworthiness of your qualitative work. And can you just reflect and say something about the trustworthiness of your study?
Okay. Thank you for this point. Typically, the trustworthiness of our work, we've tried to ensure reliability through the position or the comments by the supervision team on the first point. So reflecting on, we were doing this work and we had to keep it objectives. So we decided to merge documents and interview transcript with clear objective of what we were looking for. Second, we've tried to triangulate information from what people were saying with what was actually written in the document. And we've also used some elements of feedback from some of the actors. So the too much quantitative comments, I should confess a biomedical bias, and I was learning qualitative methods, and I've tried hard to get there, and I hope I will still improve on my qualitative method skills.
I don't know whether you can hear me, but I'm saying that in one sentence, could you just give us the take home from your work?
One sentence. The very idea of establishing knowledge translation platform within government-affiliated institutions in Cameroon and Uganda has been a good idea. It has helped change the context of health system policy making. It has strengthened the human capital for evidence-informed policy making in Uganda, but also Africa. It has to do, and it has to be much more studied as more and more issues will be raised, and the scholarship on knowledge translation and evidence-informed policy making need to be much more studied in Africa, so that some of the reputation on the context of policy making in Africa will be available to the global community. Over.
Okay, so thank you very much. Thank you. So back to you, Chair. I'll finish my questions.
Thank you, Professor Joan Kaliango and Dr. Pierre for that interaction. I think next we'll move to the public for the next 5-10 minutes. Maybe we'll start with the people here. If you have any question before we move to online members. Any question? Looks like there's none here. So we'll move to the online participants. If you have a question, you raise your hand and you can unmute yourself. I don't see any hands up online. Maybe I could ask. Okay, Professor Nachimuri.
Yeah, thank you, Pierre, for that wonderful work. I mean, it's kind of a very new area for many of us, but you have taught us several things today, which is really nice. I think there was a question in my mind. I think it was pointed out by the opponent. I would still not got a clear response. How the knowledge and skills you've acquired or what you have done could inform development of the COVID guidelines, because when we were discussing your rapid evidence synthesis, I was really paying attention keenly, because I think these rapid situations are going to be required more and more, get more emergencies evolving over time. So just a comment.
Okay, so reflecting of what has happened, the Secretariat is informing the Scientific Council, management of public health emergency in Cameroon. Typically, when there is a question raised, we have a librarian, we have one of the officers interacting with the one asking the question. Then our librarian will search for the evidence, and then myself or a colleague will try to summarize and make it available to the member of the council, or be sensitized if the question was raised by a manager, for example. And this will be like, okay, we promise we can provide this in 1 or 2 weeks based on what we have to do. Some will just ask for, is there any paper on this? And then we'll share the paper. Others will ask us to critically appraise and see how we can contextualize. So we prepare some product called evidence assessment. That is, we are looking at what is available in guideline or systematic review and try to see how it will apply to our own context. I don't know clearly what is the current arrangement in Uganda in terms of interacting with the rapid response unit, but the very process of rapid response unit has been expanded to countries like Burkina Faso as well, where they will receive questions and have the interaction and provide answer. So it's operating right now, but under different elements. The Secretariat is doing the work, but we are not moving to the deliberative dialogue as it used to be because of several constraints related to the pandemic. Yeah. And one of the biggest challenges is the quality of evidence, where it's moving quicker, and at some point in time, the very quality of this evidence is missing.
Okay. Yeah, thank you. A simple one. If you are to do this study again, or this work again, what changes would you propose, or how would you go around it?
If I won't probably, I will probably include something that we've missed, as we want to understand the point, integrating an analysis of power struggle. Definitely this will be included to try to have a better understanding of the power struggle. Now, in terms of the design, I don't think I will change anything, but I will develop the tool to try to capture the power, and probably more of participant observation to capture the power struggle during the deliberation. That will be the main change, and eventually extending the study period. Now that the platform has been acquired, we can look backwards and have enough time to see how the process has stand on a longer time frame.
Thank you. There's a hand online, Jean Cloud. Please unmute yourself and go ahead.
Yeah, and thank you, Pierre, for this presentation and the jury members. Pierre, I have a question. If you are a Minister of Health,
You are muted. Please unmute yourself. Could you please repeat the question? We seem to miss part of it.
okay. Are you hearing me?
Yes, we are hearing you.
I said I was thanking Pierre for the nice presentation, but my question was, if he is the Minister of Health in one of these countries, how would he use this research to reorganize his Ministry of Health?
Thank you for the question. The critical element will be to create the institutional arrangement to have properly funded and make it mandatory for all policy proposal to go through the process. So we are sure that we are using the best available evidence and the best consideration of the tacit knowledge on most of the policy. So institutionalize the knowledge translation platform as one of the critical units close to the cabinet with appropriate resource and a maintenance of a clearinghouse where all the evidence, policy relevant evidence will be made available, and avoid having it being dependent on external funding.
Yeah, that's good, but the WHO recommends such policies. Why is it that African governments are not applying it?
Because Africans consider themselves at some point not to be followers, they want to own their own way of doing things. This will be one of the lesson I've learned from this research by reflecting, for example, on how some of the issues were managed differently, looking, for example, at task shifting in Uganda or improving health district governance in Cameroon, the way the existing political arrangement or the local politics has influenced the outcome of the whole process has been an eye-opener for me, that we can't bring evidence without paying attention to the existing political arrangement.
Thank you, Mr. Chair.
Thank you. Looks like there is no other question or comment. I would like to bring this to an end. I think next we'll have a meeting with the examination committee. So the team will yeah, we have a breakaway room, but the other members can, as we wait for the final verdict, which will come back and let you know in a few minutes. Thank you.
Thank you, Chair. Again, having considered the written thesis, the candidates' presentation and responses to all the questions raised during the public defense, we have come to the verdict of a pass. So congratulations, Dr. Pierre Ongolo-Zogo. Thank you.
So thank you, Dr. Pierre, and congratulations, Pierre. So we'll invite the supervisors to say a word or two. We'll start with Professor Tomson. You can switch on the video and
it's already done. Now, Pierre, warm congratulations.
Thank you, Göran.
It was a pleasure listening to not only your presentation, but the intellectual discourse between you and the opponent and the examination committee. So also congratulations to them. I've known you as a very self-reliant, independent person, and you're also working in an area where not least Uganda has been in the forefront, many thanks to the other supervisor, Professor Nelson Sewankambo. As some of you may know, Karolinska Institutet, which I represent, has a historical and very positive relation to Makerere University. It has true reciprocal learning. So I have also, even though you're not registered at KI, but to Makerere, I have a warm regards to the president of Karolinska Institutet. Finally, something that you may not know, Pierre, you are historical. I have had many, many PhD students also from Uganda, and very excellent. But it's not your student from Cameroon. You're also my last PhD student in my trajectory, and I was very proud listening to you. So once again, congratulations and over.
Thank you, Göran.
thank you, Professor Göran. We'll ask Professor Nelson to have a word or two.
Well, first of all, maybe I should take up. Congratulations to Dr. Pierre Ongolo-Zogo for a great performance today and being declared having passed the defense. Pierre has presented in a very calm way. He's been very calm throughout, and I really liked that. In addition, of course, to enjoying the comment on what, the content of what he has presented, work which has taken him quite a has to do, not easy work. When it was starting, this was something generally new to the African continent. And then he was pioneering work. You know, over time, now a few more countries are engaging in these knowledge translation platforms. But thank you for keeping it going and bringing it to a successful conclusion. I know that in the end, there may have been a bit of frustration because of a delay in arranging for the defense, because it has taken some time. But of course, this is in a large part because of the COVID pandemic, which made it difficult to arrange the usual face-to-face presentation with a big audience in front of you. Before I conclude, I would really like to thank the co-supervisors. You've seen Göran Tomson. There is John Lavis, who has not been able to join because the time didn't, this was around 2 or 3 a.m. his time when the defense started, so he couldn't join at that time. But thank you very much to the co-supervisors, and also, of course, today, for the examiners who have had a good discussion, interrogation with Pierre. It's a pleasure to have had the opportunity to supervise him, and I wish him success in the future years.
Thank you, Professor Sewankambo. Next, we'll have a few remarks from Pierre on how your work has been and what your future plans are, and acknowledgements.
Thank you for giving me the floor once more. I wanted to say thank you to the panel. Thank you to my supervisors. Thank you to classmates at Karolinska, at McMaster, at Makerere. Thank you to the members. They will recognize themselves. I also want to acknowledge the World Health Organization, the European Union, the Canadian International Development Research Center for providing the funds that allow some of the activity that we've studied here to happen. I also want to thank all the stakeholders in Cameroon, in Uganda, in different ministries, from civil society, from the media, for accepting to contribute as key informants and advice on how to move ahead. I also want to give a special thanks to Dr. Andy Oxman in Oslo, who actually convinced me to go for a PhD, and it's been such an inspiration to keep this going. Finally, I want to say thank you to my family for allowing me to go back to school to complete this doctoral study. The next plans rely on God. Yes, during this PhD study, I escaped an assassination, and finally, here we are, I've completed it. So the next plan, we try to push the agenda of health policy and system research in Africa within my university, the University of Yaoundé, one in Cameroon, but also in collaboration with colleagues, those finalizing the doctoral study at Makerere, others in Burkina Faso, in South Africa, in Kenya, so that by promoting evidence-informed system policy making, most African countries will make the needed progress towards the Sustainable Development Goals by expanding the scope of this to social policy making, not just health. And may God bless all of us, and thank you.
Yeah. So you've accepted the PhD, Dr. Pierre, or after all, nothing much. us to have it back. And congratulations, I would like to join the co-chair, Dr. Kadu, in welcoming you to the world of PhDs and postdocs. But as you know, it's just the beginning. And we wish you well on your onward journey. And of course, you remain one of us, alumni of the Makerere. But we really thank the supervisors who have worked with you through this journey. All those of us who have undertaken it know how supervisors are very helpful in making you get to the end where the light is. And for PhD, there can be light at the end of the tunnel for many years. And sometimes people give up on the light, but thank you for keep going strong and completing. Congratulations once again. And for all those who have attended the online defense and here physically, thank you for your patience and for being such a wonderful audience. We wish you well, stay safe, and hopefully we shall be back here soon to welcome another PhD into the world of academia. Thank you and have a wonderful day.